So our next speaker, where there has been much in the media recently heralding that Australia is on track to wipe out cervical cancer in the next 20 years. So whilst we're patting ourselves on the back, we need to realise that there is still a real need for women in relation to improving cervical cancer treatments. In 2015, ANZGOG designed trial for cervical cancer Outback went global. It recruited 926 patients across 7 countries. This was the first Australian-designed international recruited trial in gynecological cancer, and it is still active, but recruitment has closed. Our next speaker is Dr. Michelle Harrison, who is a medical oncologist at the Chris O'Brien Lifehouse and Liverpool Hospital. She's going to present, with the advent of immunisation, why is it necessary for cervical cancer trials to continue? Please welcome Dr. Harrison to the stage.
My stool. I'd love my presentation. So just while my presentation is getting on, I'd like to thank ANZGOG as well as Karen for inviting me to give this talk. Oops. Okay, this is now my talk. So this was absolutely a fabulous question that I was asked to present on. So usually by the time someone comes to see me with cervical cancer, they've either got usually locally advanced disease or metastatic disease. So just some stock ownership, just for conflict of interest. So Australia, cervical cancer is the 3rd most common gynecological cancer, but worldwide it is the 4th most common for incidence as well as mortality. And this is based on WHO global data for women. And it's estimated that each year there are 570,000 diagnoses of cervical cancer. So this is huge. We have some risk factors of which we know about HPV being a huge risk factor. Smoking, well, smoking's on the decline. Poor screening history continues to be a problem. And really the only non-modifiable factor is actually age. So, with good screening we have seen, and this is Australian Institute of Health and Welfare data, and I'm actually going to use a lot of their data for my presentation, that the incidence of cervical cancer is decreasing over time, and with that, the mortality is decreasing over time. If we think about HPV, it's not just one virus. There are actually multiple different strains of HPV, of which the 2 ones with high oncogenic potential are HPV 16 and 18. We then have 2 other common varieties which people will know about, which is 6 and 11. These are kind of more your genital warts. And we also then have some other viruses which we think are kind of moderate risk in their oncogenic potential. So there have been a number of vaccines which have been developed, and the one which is most recent and now in the Australian vaccination process is Gardasil 9, and this covers our high-risk oncogenic, our 6 and 11 which are associated with your wart viruses, as well as some of those moderate risk genes. So if we think about HPV, we know that we start with a normal cervix, we get an HPV infection, and more often than not, we will actually get clearance of that virus. About 10% are going to persist, but you may also in that time have some very sort of mild changes within the cervix. However, with persistent infection, there is going to be a percentage of people that are going to progress to higher grade lesions in their cervix and then ultimately develop cancer. So these figures are just a snapshot of data which was taken from a large US population, looking at what is the incidence of HPV. And in the 14 to 19 women, it was 25% and 45% for women aged 20 to 24. So that's quite high in very young women. And it's estimated that around 8 out of 10 women are going to have HPV at some stage. So if we think about, well, how often does HPV cause high-grade cervical changes or cancer? These are incidence figures over about a 10-year period, and they do really relate to which strain of HPV you have. So 17.2% for type 16, 13.6% for HPV 18, very small amounts for your other oncogenic, less oncogenic types, around 3%. So quite high incidence of having high-grade cervical changes if you do manage to get this virus. If we look at the HPV vaccine trials, there have been a number which have been done, and certainly there's been a whole range of different ones, including the ages, how many sexual partners that you may have had, and so they're not all kind of the same. They're not your young adolescent, never had any sexual exposure populations, but nonetheless, when they did these trials, they were able to find quite a marked difference in the rate of high-grade CIN or cancer, and their endpoint was CIN, not waiting for people to get cancer. So we have the Australian HPV vaccination program, which was introduced for girls in 2007 and then 2013 for boys. So at the moment we give Gardasil as a school-based program. For those under the age of 14, there are 2 injections which are given, and for those over the age of 14, if they've not yet been vaccinated, it's thought that they probably need 3. They don't respond quite as well, and so they prefer to give that 3rd injection. So, vaccinating, hopefully, all our school-aged children. Does this mean the end of cervical cancer? Well, we'd like it to eventually, but certainly in the near future, unfortunately not. So I thought of 4 main reasons as to why we're going to still continue to see cervical cancer to be a problem. We do have a large number of unvaccinated populations. We do need greater uptake of HPV vaccination. Cervical cancer screening, like all cancer screenings, has always been difficult. We need greater uptake there. And then also, finally, we do have an unmet need for effective cancer treatments. So just starting with the unvaccinated population. So if we go back to the inception of this program in 2007, we're looking really at vaccinating within year 7's age. So basically that's about 12 to 13. There is a catch-up program which is available for those up to 19, but also for older people who are not included, you can go to your GP and you can actually self-fund the vaccine. So if we sort of think about, well, what does that mean for our population? Most females over the age of 25 have not received an HPV vaccine. And if we look at the incidence of cancer, and this is by 10-year marks, so we can see that it's going down over time if we look at 10-year time periods. But what I just want you to appreciate is when those curves start going up, it's around the age of 25 and up where we're starting to see cervical cancer. So this is our unvaccinated population. The next problem is the uptake of HPV vaccine, and I'm going to read this out because I really find it not what I would usually recommend, but you know, this is a website, The Truth About Cancer, and it's not a favoured website by myself. Either way, millions of girls and young women have been tricked into getting an unnecessary vaccination for an unlikely disease while endangering their health now and in the future. Know the HPV vaccine fact. There are lots of people who do not like vaccination. But this vaccine is safe. It's been tested on many women. This is a safe vaccine, but unfortunately, there are a lot of people who do like to, for whatever reason, discourage people from having HPV vaccination and other vaccinations. So what are the vaccination rates? So again, Australian Institute of Health and Welfare, I got this data. If we look at girls in 2017, overall rate was around 80, so 1 in 5 not vaccinated. What impressed me was Northern Territory. How fabulous are they? They're winning. So, you know, it's a remote community. I thought that was really impressive, but 1 in 5 of us girls not getting vaccinated. If we look at boys, we won herd immunity. They're down at 75% roughly, so you're looking at, you know, they're 1 in 4 not getting vaccinated. That's not great. But we're also going to get some side effects. So while this has been principally developed as an HPV for cervical cancer vaccine, we've got all these additional benefits which are going to come along. And this is not only in vulvar cancer, but vaginal cancer, they are relatively rare, but anal cancers and head and neck. So we would expect with vaccination that we are not only going to get a reduction in cervical cancer, but get a side benefit from all these other cancers. Screening. Previous guidelines, we had to go get I say we as females, men, not you. In the room, us females were recommended to get pap smears every 2 years from the age of 18 to 69. New guidelines, which came in December 2017, said we had to do a HPV test every 5 years from the age of 25. And it included women who've already had the vaccine. So we want to make sure the vaccine is still doing its job, and to date, 10 years they're still collecting the data and it does appear to be holding, but we don't want to become complacent, so we still need to be checking those women. It does lead to a much more complicated sort of schema about what we do, but essentially if we detect HPV and we then need to do a pap smear, and then patients will then follow this different scheme depending on what it's found. But by and large, I would say that most women, if they're advised that they can just have this test every 2 years or change to HPV 5 years, look, I think it's an amazing change for females who love having their pap smears, but also it's more effective, and that's why we've changed how we screen. So these are going back to older figures of pap smear. Look, the rates are awful of screening. About 60% all up. And, you know, while it's a little bit better in major cities compared to remote, I'd actually say it's quite poor globally. And if you look at the socioeconomic data, you know, we often say that people of lower socioeconomic groups are not getting screened that much, and those of high socioeconomic groups much more. Actually, yes, a little bit more, but I still think very, very low. So why does screening work? It's because we get multiple looks. So screening is not a diagnostic test for cervical cancer, but we are trying to pick up early changes which will then lead to, hopefully with treating of these high-grade diseases or monitoring of the low-grade changes, prevent cancer. So if you don't have this screening, it's the poor screening history which is going to put you at risk of cervical cancer. So we absolutely need to emphasise screening. But we're not only bad at screening for cervical cancer. Women, our breast cancer screening is, I was actually surprised. I would have thought our breast screening figures were better than they were. Colon cancer screening, by the age of 50, you get sent a kit in the mail by the government. They're about 40%. So as a whole population base, we have very good screening, but we don't take it up. And this is really the talk about unmet need. So for people who are diagnosed with cervical cancer, their outcome is going to be related to the stage diagnosis. And for what I'm seeing for my patients, I'm often seeing people who've got relatively advanced stage 2A and beyond disease or metastatic disease. And so you can see for the group of patients that see me, their outcomes are relatively poor, and they are likely, unfortunately, to die of cervical cancer. Effective treatment, well, how do we treat them for early stage disease? It's often surgery. It's been mentioned, you know, with Di talking about endometrial cancer, but fertility treatments, fertility can be affected in these young women. We cannot always do fertility sparing surgeries. And then for the more advanced tumours, we're really looking at chemotherapy and radiation, which does have long-term toxicities for the patient. If we think about metastatic disease, that's my involvement, but we give chemotherapy with carboplatin paclitaxel plus or minus a drug called bevacizumab. But after you have failed first-line chemotherapy, unlike other cancers where I've got lots of different treatments that I can try, I don't have a second-line treatment. It is really best supportive care. So if we think about what have been the advances in 20 years, I could really only find two. So the NCI alert was in 1999. This was on the back of multiple trials of chemotherapy with radiotherapy. And it said that concomitant cisplatin-based chemoradiotherapy should be considered instead of radiotherapy alone in women with cervical cancer. And this was looking at about just shy of a 10% benefit in terms of local control and survival. The second one came many years later, in fact 15 years later. And this was when we found out the addition of bevacizumab to chemotherapy provided a 3.7 month survival advantage, and that's for patients with metastatic disease, people who are ultimately going to die of their disease. So that's it. And then if you're diagnosed with cervical cancer, has your outcome improved? We know that the overall incidence and therefore mortality is improved. But if you're diagnosed with cancer, have we done any better over time? That is a horribly flat line. So, in answer to your question, Karen, with the advent of immunisation, why is it necessary for cervical cancer clinical trials to continue? And my answer to you is to try and save the lives of lives and provide more effective treatment for the many hundreds of thousands of women who are going to be diagnosed with cervical cancer in our lifetime. And HPV vaccination is the greatest step forward to date that we have for preventing disease. And I'm an unapologetic, proud mother of these two beautiful girls. This is my Kira and Madison. They will be vaccinated when they get a little bit older, but we really do need to try our best to eradicate this disease, but we do need to continue because it's going to be some time before that occurs. So with that, I'm going to say thank you very much for listening, and I hope it's been very thought-provoking.
Could you tell me what the positive rate for HPV, since they've been testing for HPV, is? Like how many in 100 or 100,000 or whatever?
So basically it's incredibly effective. So to date, when they've done studies 10 years on to look at women who were in the vaccination trials, they do not appear to be getting HPV infections. So
No, after the current new paradigm as far as HPV testing goes, what's the positive rate as to negative rate?
I don't
So
have...
uptake, prevalence of HPV virus in the population. I think that's a question.
Oh, that's right. I don't know that data.
I hear there's a 6 month waiting list once they're positive to have to see a gynae. Is that right?
I see patients who've been diagnosed with metastatic or locally advanced disease, so I don't know those rates. I'd be very concerned if that was actually the waiting time.
And further, I hear that they're sent to family planning where the nurses do what the gynaes are doing, looking for white spots in order to overcome the shortage of gynecologists.
It's a little bit outside my area, so I'm a medical oncologist rather than a GP or someone who's in that primary health care. I just a little bit outside where I think I can give you the right answer to the question that you have.
That's okay.
Beautiful questions, but I just don't want to give you the wrong answer by guessing.
That's okay.
Do you have any other questions?
Is there an upper age limit to when you can have the vaccine?
No, there's not an upper age limit. The problem is if you vaccinate older people, that they are very likely to have already been exposed to the virus, and it's probably not that effective in people who already do have that re-exposure. So when they did the trials, the preventative trials, there were women and they weren't selected for whether HPV positive at the time that they went in for the trial, and it's probably why you did see that incidence even in the vaccinated as well as placebo of people who had some changes. Most women, by the time that they reach their 20s, will have had HPV exposure, and there's also, I remember seeing another statistic when I was looking at this, is even after females' first sexual exposure within a couple of months, the rate of HPV infection detected is about 30%. So it's just an incredibly prevalent virus.
Okay, very much for